We've heard two very high-level presentations. I'm now going to go down to a much more nitty-gritty kind of presentation where I'm talking about some work that I'm doing primarily with Chandra Gould, who's a colleague based at the Institute for Security Studies, which is an Africa-wide NGO which looks at violence prevention, amongst other things, and Rachel Bray, who's a research associate in the Department of Social Policy and Intervention at Oxford University. And Rachel's been looking at family policy across Europe and has been very helpful in helping us think about how we're going to do these things. So all of my work today is based in the Western Cape, which is one of the 9 provinces of South Africa. Capital city is Cape Town, which is about here, and there are about 5 to 6 million people in the province, most of whom, 3 to 4 million, actually live in Greater Cape Town. And we're at a policy moment, particularly in the Western Cape, although there are some national movements as well, about starting to provide early intervention and prevention programs for parents, primarily to prevent child maltreatment. But Chandra and I have also snuck in a thing about child conduct disorder as well, and we've got some policy stuff to back us up. So I'm going to talk to you briefly about parenting programs as a means towards reducing violence. Francis did that beautifully, so we'll skip over it really fast. And then I'm going to talk to you about what we're doing so far in the Western Cape. So why parenting programs have shown promise as a means of reducing child maltreatment, which of course is a precursor for other forms of violence. The children who've been maltreated are at risk for all kinds of other forms of violence, and as a means of reducing child conduct problems. And so there are two ways that parenting programs can reduce violence. And then we started to think, so this is where we start to think about now, how, if we're going to take these things to scale, what do we have to do? Now there's a fair amount of work in the literature from people like the Society for Prevention Research and so on, who've given us some standards for rolling out programs. And very briefly, those are ones that have evidence of effectiveness. They need to be manualized. They need to have a clear theory of change. There's got to be training and technical support available. There's got to be an available workforce. Those that have been costed, so the programs have to be costed, and monitoring and evaluation is possible, and that's particularly to ensure fidelity of implementation. Now, those are the standards that you have, I think, when you sit in Washington, D.C., and you think about what would we do. We're in a low and middle income country, and I'm going to show you a little bit about how we have worked with this as really as an aspirational guide and not as something that we can do today. And what sorts of parenting programs do we need for violence prevention? We need attachment-based programs in the early years, because good attachment between parent and child gives children a good working model for relationships, and basically what it does is to build empathy. I think it probably builds empathy from the parent towards the child as well, so they're less likely to maltreat their children, but this is something we haven't really studied in the literature. Behavior management, so that's programs that help parents with non-violent discipline, reduces harsh and inconsistent discipline, so it reduces the kinds of parenting that is a precursor to child maltreatment and also helps with behavior management. And then we have one longitudinal study from Jamaica, which they provided cognitive stimulation to impoverished, malnourished children, and followed them in an RCT over 20 years, and they did not do a waitlist control, so now we know what those kids are like at age 20. And there's a really nice paper from the group in pediatrics which shows that on self-report, the kids who got the cognitive stimulation are less likely to be violent than the kids in the control group, and in fact more likely to do well at school and to be better employed. And I think the more likely to do well at school and the better employed probably plays a role in the less violent as well. So we have, and I'm very proud of the fact that makes ABC, attachment, behavior management and cognitive stimulation for reducing violence. So what are we doing in the Western Cape? Now, we did a policy review. It's a very easy thing to do at the moment because everybody in the country is talking about child maltreatment and violence prevention. Now, there's quite a lot of policy around this, so just to give you some flavour. At a national level, we have an act called the Children's Act, which really sets the sort of governance for children's lives. Everything from parental access, when parents get divorced, to when children are in absolutely untenable situations and have to be removed from their families. And it also mandates prevention and early intervention programs and specifically says parenting. Now, our child protection services are overwhelmed and all of their effort has gone into statutory removals of children. But the Department of Social Development has recently produced a draft plan for draft national strategic plan for prevention and early intervention, which again, a whole lot of stuff on parenting programs. So that's two pieces of national policy. In the Western Cape, if you came to Richard Matsopoulos' presentation yesterday, Richard led the development of the, try to get these things right, the Integrated Violence Prevention Policy Framework. And one of the four legs of that is safe, stable, nurturing relationships between parents and children. So thanks to Richard. Right up front and centre in terms of violence prevention, we have parenting programs as a long-term strategy. And then very recently the province has produced the National Youth Development of the Provincial Youth Development Strategy, and that set a goal of reaching 100,000 families in 5 years. Now, they admit that that's aspirational. They had no basis for setting that goal. They have no idea if it's achievable. But they set the goal, and it's really targeting parenting. So I had this delightful experience. I knew about the Violence Prevention Policy Framework, so I got hold of the Policy Directorate in the Department of the Premier, and I said, can I come and tell you about all the work I'm doing in parenting? And they said, sure. So I went into a meeting, and Solange Rosa, who's the wonderful woman who leads policy development in the province, said, well, wouldn't you like us to help us develop a strategy for rolling out parenting programs to scale? So I went, yes, why not? This would be an absolutely fabulous opportunity. So we did the policy review, we did a little bit of a look at the state of the evidence of parenting programs in South Africa, and then we started to develop a theory of change. So what's the state of the evidence in South Africa? We have two parenting programs which really come from the same group. One is an attachment-focused program. It's one of the few RCTs in low and middle-income countries. And the second is going to come out shortly. It's a dialogic reading. You get parents and children to read together. It's a cognitive stimulation program. Those are the two that we have at the moment. And Mark Tomlinson isn't in this session. He is at the conference, but he's been a leading light in getting those off the ground. Then we have others in trials at the moment. So Francis mentioned Parenting for Lifelong Health, and the top two programs are those two programs are part of PLH, and the next two, if we get some evidence, will be with Francis and other colleagues from Oxford and Bangor, and with Jamie. We've got a behaviour management program intended to reduce child maltreatment and improve children's conduct for parents of children aged 2 to 9. And Lucy Kluver, the same group, really is leading a similar program for parents and teens aged 10 to 17. We have a strong NGO in Cape Town called the Parent Centre that also has a positive parenting skills training program. They asked me if I would evaluate it, so I have a student at the moment who's doing an RCT on that program. And they say parents aged 6 to 12, but really they take anybody who walks through the door. We've tried to streamline them a little bit for the purposes of testing it, so that we could have instruments that actually were the same for every parent. And then Rachel Jukes is at the conference. She has been leading the development of an intimate partner violence reduction program. And she's doing a 3-armed RCT where there's a group of schools that get nothing, a group of schools that get a grade 8 life skills curriculum. We have life skills as a core part of our curriculum in schools. And the third arm gets life skills plus a parenting intervention that looks very much like ours. And that's also going through an RCT at the moment. So that's really where we are. One of the things that I have had to do is to manage my own conflict of interest because I'm involved in 3 of these trials. And I've had to be very explicit about that with policymakers. It hasn't really been a problem at the moment. But I've had to be explicit that actually my interest really in the overarching sense is making children's and families' lives better and not really promoting my own programs. And there is the chance that the programs I'm testing won't work. We hope they do, but there is a chance that they won't work. So then we get on to developing the theory of change. So now I remember going away on holiday when I lived in the States with a friend and her brother, and as we were packing the car to drive to New York City, John said to me, "You really think of everything, don't you?" And this is the moment where we're packing the car. So we've tried to think of everything. In about 5 years' time, we may discover that we left something out, we packed too much. We're not entirely sure. But these are the sort of 8 areas we've looked at. So critical assumptions, what are the principles for program selection, how do we recruit and retain families, what's the distribution and location of services, There's a lot of stuff about the practical realities of delivering programs. Timing, fidelity, and sustainability issues raised a whole bunch of questions. There are some important ancillary services that we, in conversation with folks, we thought we needed. And we have to think about monitoring and evaluation. So very much a work in progress, and I hope you all pay close attention and tell me what we've left out and where we might have packed too much. And it really is very early days. We've had 4 meetings with the Provincial Working Group. It started out with the Department of the Premier, who very quickly brought on Departments of Health and of Social Development, which are line function departments. So in the sort of alphabet soup of government in the Western Cape, the Department of the Premier helps with policy stuff, but then they're handed over to be implemented to line function departments. And then realise that there are a whole lot of other folks who are interested in safety and security. So we've got a Department of Community Safety, we've got the Western Cape Education Department, also has interests in parents and children. And the City of Cape Town, which is where the majority of our population lives, are also doing some work with parenting. So they are rolling out the Strengthening Families program. Unfortunately, they're not doing any kind of RCT. They are doing a pre-post, and we hope they'll get an RCT. But they're doing that on a small scale. So we've had 4 sort of consultations with a working group that's growing and is quite an amorphous group and hasn't got a clear sense of where it's heading yet. And then Chandra and I have spent quite a bit of time driving around the province talking to people who are rolling out parenting programs, who could be potential agencies for delivery, who are agencies who, like the Department of Health, who are doing work that touches on parenting, and we're chatting to them about their service needs and where the sort of overlap is. So what I'm going to do now is walk you through this. As you will see, quite often we still have a lot of questions. There's a lot of things we haven't been able to resolve yet, but we have achieved some things. So one of the things that I really was quite surprised about was we said up front, we're only going to roll out evidence-based programs. And they all said, oh yes, that's fine. Now, I think that Solange Rosa, who is in the Department of the Premier, comes from an academic background. The Department of Health folk come from a public health, the woman who's leading this initiative comes from a public health background. And so she's got an evidence-based approach to the world. I'm going to see how this plays out in practice. As I was saying to Nancy yesterday, we've got... There's a parenting program in the province that's very, very skillful at marketing and has managed to get all of these departments to buy their material and let them roll it out. And they tell the most marvelous anecdotes, and they have none of the evidence that we would consider evidence-based. What we've done is we've said we want to head roughly for something like the blueprints criteria. Now, at the moment, we've got 1 RCT with 1-year follow-ups for the 2 programs that we have that have any kind of an evidence base at the moment. So that's the criterion we have set. Obviously, as Nancy and Francis have said, really the strongest evidence is where you have an independent evaluator doing an independent replication, again with a 1-year follow-up. And we're not going to be able to get that far at the moment. So we've set it at a slightly lower level. And I think we're extremely fortunate in the Western Cape province of South Africa that there are so many parenting programs that are in fact going through RCTs. And there are others that are hoping to do RCTs, like Sonke Gender Justice, which is a big gender NGO, has what is potentially a lovely program for expectant fathers. And they really want to do an RCT of that, which will be absolutely fantastic. What we've also realised is there isn't a single organisation across the province that could do this rollout. So we're going to have to work with multiple agencies. There also isn't an existing workforce that can do this at scale. So in our program, for instance, we have 4 trained facilitators, and we will be able to reach, Jamie, 150 families this year. Is that about right? I'm trying to think. Yeah. So, and actually, when I talk to other agencies, they're reaching 30 families a year, 50 families a year. They're not reaching anything like 150 even. And that's probably because our staff are dedicated to the parenting program. But to reach 100,000 families, we don't have an existing workforce. And the other thing that we've been very, very clear about is these are prevention and early intervention programs. We're not dealing with kids who need multi-systemic therapy, who already are in the criminal justice system and that kind of thing. We're really talking about prevention and early intervention. And that's in line with the policy thrust and the sort of policy moment that we have in the country at the moment. So we're going to need to build the evidence base. And as I said, there's still some lack of clarity, and I'm waiting for the policymakers to turn around and say, well, we really want the sort of fuzzy programs to tell us nice stories to be brought on board. What they're also doing is talking about what they've done in other program areas, is having 2 to 3 programs available per age group, and agencies can then choose from one of those. That makes me quite nervous, because if you're going to manage training and implementation with fidelity, I'm imagining we're not going to have a lot of staff to do that. And so I think the smaller the number of programs we have, quite possibly the better. But this may be a political reality that we need to juggle. So we're just going to have to see. Now, the nice thing about this work is that the 2 programs that we do have that have an evidence base, the attachment program and the book sharing program, are both targeted at the early years. That fits very nicely with the Department of Health, which is really with their agenda, because they're really pushing the first 1,000 days. And so is the Department of Social Development and our Western Cape Education Department. And so there is a policy moment around the first 1,000 days. So that's where we're going to start. And then we'll have to find a mechanism for phasing in other programs as they become evidence-based. So that's really where we are at the moment, but we have some unanswered questions. We haven't said to the state yet, if you really want evidence-based programs, please put some money for evaluation on the table. In fact, they are funding my students' work at a very small level. They've given us about $4,000 towards that work, which is really helping. But it's not, as those of you who do RCTs will know, that's not really enough to do a full, a big RCT. And also we were wondering if they want to put a time frame on the development of evidence, or whether they want some kind of open-ended thing where we can bring in programs as they develop evidence. Then recruitment and retention of families was an issue. One of the very tricky issues with programs is stigma. Both Chandra and I, in separate contexts, have had issues with families who will have absolutely nothing to do with an agency that has been mandated to remove children. Low-income parents and vulnerable families are terrified that their children are going to be removed. So if we brand this as being a child welfare program or a Department of Social Development program, quite possibly we've lost the whole thing right at the beginning, because parents really are very, very anxious about that. And quite often, in some cases, I'm sad to say, with justification, because overloaded social workers have sometimes made bad decisions. And that gets back to families, inevitably. Similarly, Rachel has found in her policy level review that stigmatized programs just don't work. Parents just don't come. And that's a sort of sine qua non. If your parents don't come, you can't evaluate anything, you can't change anything. And so the first thing to do is to reduce stigma to get parents through the door. So we're going to have to think about that. And that has implications for which programs, if organizations are going to refer, how we educate them to refer, the kinds of information that they're instructed to give parents, that they don't say, you are a bad parent and therefore you must have this program. And so that's got implications too for how we advertise and how we sell the programs. And really it's quite easy with the ones we have at the moment. If you have an attachment-based program for first-time mums, you can bill it as part of antenatal care. If you've got a book sharing program, you can bill it as part of getting your children to have a good start in school. But it's a little trickier when you're trying to change child conduct problems. And there's a very fine line between a bad child whose parent needs a program and a bad parent who needs a program. So we haven't solved that conundrum yet, but it's one of the things that we really have in mind for taking things to scale. So, distribution and location of services. Can programs be an add-on to existing services? Now, we use an enormous number of paraprofessionals, and let me just say at the get-go, when we're talking about existing workforce, we're never going to be able to take this to scale with social workers and psychologists. I doubt that you could do that even in a high-income context, really. You're probably going to rely on paraprofessionals. In my context, there just aren't enough professionals. There are plenty of people who could potentially be available. There are social auxiliary workers. This is it's a sort of half a social worker. And it's a special registration category intended to meet need, and they function under the supervision of a licensed social worker, but actually there aren't enough jobs for them. So there are many more of them who are trained but haven't got jobs. And there are all of the programs that operate are using lay community members and have not had a problem finding really good folks to work with. That's how we're doing our programs, and I would say our folks are absolutely fantastic. There are also a number of psychologists in private practice who would love to do supervision as a part-time part of things, and so we've got a sense that there are folks who could be trained. What we are nervous about is that the Department of Health, just I'm picking on an example here, have a cadre of workers they call community health workers. They pay them $150 a month to do 4 hours of work a day, which I think is iniquitous. And it started out as being a kind of home-based care, changing dressings, doing a little bit of perhaps limb movements with people who've had strokes and that kind of thing. Over time, as people have realized the value of this cadre of workers, they've added more and more and more to their responsibilities. Now they're responsible for checking medication adherence in HIV and TB. They're responsible for identifying pregnant women and getting them into antenatal care. They're responsible for breastfeeding advice for women who've given birth. So their responsibilities have really multiplied. And in terms of parenting programs, I don't think we can then say to these same community workers, and now you must run parenting programs, because I think that's an overload. I think they will get confused, and I think the families that they serve will get confused, and certainly it can't be fitted into their existing 4 hours per day. So one of the arguments that we are making to our province is you're going to have to fund a separate cadre of workers. But it doesn't mean that we can't integrate these things into existing services. So if we are going to do an early attachment intervention, 99% of women in the province go to a public health facility for antenatal care, and they have at least one antenatal visit. And the health department's got really great stats on this. So that automatically means that there's a small change to the antenatal care protocol, and the nurse would say, please go and meet with a worker down the hall who will talk to you about what to expect when your baby is born and the first few months of your baby's life, and they can stitch them into the program. And it's also possible, we know from experience, because this particular attachment program is in fact being run by the parent centre at the moment, just not at scale, that they get asked an enormous number of other questions from the moms when they go into the home. Inevitably, they are the parenting experts, so when mom is having difficulty with breastfeeding, the Tulisana, which is the name of the program, the Tulisana worker gets asked for some help with that. And we could really, if we take this to scale, kind of stitch it into the provincial referral resources much better, I think. And then there's some discussion about the geographic location of services. We have agreement that they won't only be in the city, although that's very tempting, because obviously there's an available workforce in the city. There's most of the population is in the city. But we have some agreement that it will be targeted to high-risk areas, which means areas with high levels of substance abuse, high levels of violence, and high levels of teen pregnancy. So those are the sort of three indicators that the province likes to use as a geographic area of difficulty. Thanks, Nancy. Then, wherever in the province there is to be a program, there's got to be an agency capable of holding it, so that raises issues of who accredits these agencies and how are we going to do that. Now, some very nice work has been done in Norway with Parent Management Training Oregon, where they took that to scale across Norway, and they did a wonderful, it's one of the few national rollouts where they did not lose effect as they rolled the program out more widely. So we're looking at that as a model. Now, this is the bit where I start to think we may have arguments with province when they realize how much this costs, but they had a hub that held the training, the monitoring, the evaluation. And I think those folks would be the right folks to do the accreditation of agencies as well. So we're hoping that the province is going to agree to an independent hub, maybe located at the Medical Research Council or the Institute for Security Studies or even at the university, who will do the kind of practical holding of this thing at scale. We need to train really well. And that's where I'm worried about having too many programs, because if we have this hub and we've got some good trainers, I think you can only hold so many programs in your head when you're doing training, and so we've got to manage those two. And then again, what settings will be used, this comes back in part to the stigma issue. Settings have to be close to parents. Parents have got to be able to access them. So we can't do settings in central locations. We've got to do it close to where parents are. And we probably have to have settings where we can provide transport, childcare, and meals, because those seem to be the things that really reduce the barriers for parents to come to programs. So we have broad agreement that careful ongoing supervision is really essential, and that's really nice, because I thought we were going to lose that battle. But actually that seems to have passed by province with hardly a whisper. They kind of accept that. And it really is essential, as Francis was saying, it's not only about the content of the program, but it's also about the process. Because if you deliver these programs in a collaborative way that really respects the parents, then you get engagement and uptake and change. And so we have to have supervision to manage that, because the relational aspects are really important. In terms of timing, we're going to have to start in the city, primarily because the people who are qualified to train are based in Cape Town, and certainly when it comes to the attachment-based program, they can't be away from their private practices for very long. So we're going to have to start with training trainers in Cape Town who then train under supervision before they go out to the more rural areas of the province. As I've said, we're hoping to have this implementation and research centre that would hold the training and the monitoring and the evaluation so that we can really learn from this and not, the attempt is not to lose effect as we go to scale. And we also need to attend to career pathing for our community workers, because if we bring people in, after a few years they're going to want to grow professionally, and so we're going to have to develop a system that allows them to go up. And at the moment there really is no such system at the moment, and probably we're going to have to build this into formal qualifications like social auxiliary worker training as well. Then I mentioned briefly ancillary services. So the experience of folks who run parenting programs is that you need to be able to make referrals. If you go into a family to do a home visit and they don't have any food, you're not going to get very far with the parenting program, and so you need to be able to refer them to places where they can get food parcels and that kind of thing. So intimate partner violence, food parcels, social grants, all of that kind of stuff, we need to have a referral source, and that's probably not too hard to do in our province, which is reasonably well resourced. Then there's monitoring and evaluation. Monitoring and evaluation of the training, the fidelity of implementation. In the ideal world, we don't want just to see whether the parents are coming, which is the way the province currently does these things. You get the money from province to do 40 parents worth of parent training, and you demonstrate that you had 40 parents through the door. We actually would like to go further to see whether effect is maintained. So this is the part where we're still living in the realm of what may turn out to be fantasy. Accreditation of agencies, etc., etc. It's really important that we have this implementation and research centre that can really help us learn as we go to scale, that can think about the barriers and the facilitators for parents to attend, and help us to do kind of action learning research as we go with this, because none of us has done this stuff before, and certainly the province actually hasn't done anything to scale before. So, can it be done? The first point really is that there is political will, it's really tremendously exciting to be in a place where there is political will like this. We do have some programs that are ready to go, and we have some programs that are on the boil, and hopefully all going well won't be too much longer. Now, I think the weakness where we are at the moment, I did a costing for taking the book, the two early child development programs to scale. We can do it with, I think, 8 trainers, and I forget how many supervisors, and 1,200 parent facilitators. And that works out at 4,106 Rand and 14 cents per family, and I translated it into US dollars, I think, on Sunday. So that's what it was on Sunday, but about $370 per family. Now, we were strategically saying per family and not per child, because we think the effects will generalize in the family. We think it's a bigger win. But what I don't have is any cost effectiveness data. We don't know what child conduct problems and child maltreatment cost in South Africa. And so I've got no way of saying, you put this 4,000 Rand, which is actually quite a lot of money. I think they're thinking about spending 100 Rand if they can get away with it. If I say to them, you put that amount of money into a family, you're going to save 20,000 Rand in 20 years' time, that would be absolutely fantastic. But we just don't have that data at the moment. So that's where we are at the moment, and if you've got questions, ideas, comments to pass on, I'd be really, really grateful. Thank you.